You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 5th, 2024. Our topic is dermatology for the allergist. This is presented by Dr. Marc Serota from Peak Dermatology in Littleton, Colorado. He is board certified in allergy immunology and dermatology.
Well, yeah, thanks everyone for joining today. So again, my name is Marc Serota. I'm a dermatologist in Denver, Colorado. Before dermatology, I did a pediatric residency in New York, Cohen's Children's Hospital, and then I did an allergy immunology fellowship at Children's Mercy in Kansas City. So, I found in my allergy fellowship that see a lot of dermatology complaints, but you get relatively little experience in the dermatology world in the context of an allergy fellowship. I think some allergy fellows probably do no dermatology rotations. I was fortunate enough to be able to do a month with the dermatologist, and that sparked my interest in doing a dermatology residency as a second residency. So right after my fellowship, I started a dermatology residency. And pretty much the first thing I did after I took my derm boards when I finished my derm residency was to create this talk, which is dermatology for the allergist. And I tried to think of things that would be relevant to an allergist that you would see in your practice that are mimics of the things that you normally see. So this is going to be a know what you don't know talk, and just a bread and butter to be the best allergist I can be. Here's the things that I need to know about dermatology, and that's really what. So this talk's going to be a mile wide and inch deep. I'm not going to go into each disease in detail. I could spend an hour giving a lecture on each disease, but that's not the goal. The goal is to give you a differential diagnosis in your head when you're seeing the common things that you see, to make sure you're not missing something else that might be a totally different disease and might be treated completely differently. So these are my disclosures. I'm a consultant for various pharmaceutical companies, lecturing for them on their medications and the science behind them. None of them are particularly relevant to this talk. I'm really not going to go into specific treatments. I certainly do lots of other talks on those subjects, but none of them are really going to be relevant here. So like I said, I was an allergist first. This is going to be a mile wide and inch deep, and it's going to be practical dermatology to help improve your practice. So interestingly, we're not going to focus on some of the common diseases that you would think of. We're going to focus on mimics of those things. So things like diseases that are related to atopic dermatitis, mimics of allergic disease, and then I want to focus on some diseases that are not to be missed. When that walks into your office, you really need to diagnose it on the first try. Otherwise, the person can have morbidity or, in rare cases, mortality. So focus on some diseases that when it walks in, you want to try to get it right off the bat. So objectives, we're going to review proper ways to describe skin findings. If you describe skin findings really well and you use the terminology that I'll review with you here, most dermatologists can know what you're talking about and make a diagnosis without even seeing the rash or seeing the patient themselves. Not in all cases, but if you do a good job describing a rash, most dermatologists can at least give you a very good differential of what it might be. We're going to discuss commonly encountered skin conditions, focusing again on the mimics of allergic disease, and we're going to understand dermatologic treatment options and diagnostic modalities, and we'll do that along the way. So if I give a certain diagnosis, I'll give the bullet points of what treatments we would typically use for that. So we're not going to focus on the things that you probably thought this talk was about. So we're not going to focus on atopic dermatitis, allergic contact, irritant, urticaria, and drug rashes. I love all these topics. I think I could give at least hour-long lectures on all of them, but that's not the point of this talk, because you know a lot about these diagnoses. You could probably give lectures on these. So the idea is, when is it not urticaria? When is it not atopic dermatitis? When is it not allergic contact, etc.? What else do I need to be thinking about? So a few tools of the trade in dermatology. The one in the top left is probably the one I use the most, which is my dermatoscope. So it's simply a magnifier with a light attached, and you actually have two different types of light. One is polarized, one is non-polarized. We use those types of light more for pigmented lesions, not really relevant to you. But sometimes if you're looking at a skin lesion, you need some more magnification. It's very helpful to look up close. And there are textbooks on how different skin findings associated with dermoscopy. So if you're not very familiar with that, definitely something that's a useful tool to invest in. It's sort of the stethoscope of the dermatology world. Shave biopsy and punch biopsy, very, very useful tools when we need them. So those are the middle two tools there. If we want to get tissue and look at something under the microscope, We also can use the microscope in our office and scrape the skin with something like a 15 blade, like you see on the bottom left, put maybe some KOH on the slide and look at it to see if there's fungal elements, for example, or put some mineral oil on the slide and look to see if there's elements of scabies, for example. So we have microscopes in our office at our disposal, and then you can also just get tissue and send it off to the pathologist using a biopsy technique. If you're not comfortable or familiar with skin biopsy, I very much advocate that every allergist should be comfortable doing skin biopsies. You're seeing the rash in its most acute form right then. It could take months to get in to see a dermatologist sometimes, and you should be comfortable taking the tissue, even if you're not that comfortable reading the pathology. Getting the tissue at the time when the person has the rash that's most active is very, very useful. If you're not comfortable doing skin biopsies, I'm one of the instructors at the workshops, at the college meeting. I've done the academy meeting before, but we'll teach you how to do a punch biopsy and a shave biopsy. Very, very easy to do. If you're comfortable doing other techniques in the allergy world, there's no reason you shouldn't be comfortable doing a skin biopsy. And then on the bottom right is dioscopy, which is where you press a microscope slide against the rash to see if it blanches. So two broad concepts. One of my mentors in dermatology said dermatology basically breaks down into two things: growths or rashes. So I crossed out growths because you're not a dermatologist, you're not going to be evaluating for skin cancer, so you could just eliminate growths right there, and we're going to focus on rashes. Okay, before I get off growth though, one slide on growths, because this might be the most important slide of this whole talk, even though it's not really relevant to your specialty, because you could save someone's life. So these are the A, B, C, D, E's of melanoma, or abnormal moles. So A is for asymmetry, B is for regular borders, C is for color, D is diameter, E is evolution, something that's growing or changing over time. So if you don't remember any of that, remember the ugly duckling. If something is very different than the other spots on your body, it's violating some of these rules, it's bleeding, it's changing, don't ignore that. This is what melanoma looks like, and if left undiagnosed, this could potentially kill somebody. And if you think this is just pie in the sky, I gave this talk several years ago to the Colorado Allergy Society, and about a week later, they were one of the doctors in attendance, one of the allergists, referred this patient to my office. They said, "Hey, Mark, this looks like an ugly duckling. It's violating some of the rules you mentioned." We biopsied it. It was a melanoma. It's obviously very close to this person's eye. Fortunately, it was caught relatively early, and they had an excision and did fine and did not have any other morbidity associated with this lesion. But this was sent to us by an allergist who saw this talk about a week prior. So in case you think that's pie in the sky, just burn these things in your brain, because you might save someone's life one day. Okay, so how do we describe skin lesions? I think about nouns and adjectives, okay? So the noun is the primary lesion, the adjective is the secondary lesion that basically describes the primary lesion. So you can have a scaly patch or a crusted plaque or an excoriated papule or whatever. So the secondary lesion describes the primary lesion. And if you're not sure what all of the definitions of these things are, let's go over them. So a macule is less than 1 centimeter and it's totally flat. If you closed your eyes, you would not feel a macule. So less than 1 centimeter flat is a macule. Greater than 1 centimeter and flat is a patch, something like a cafe au lait spot or a patch of vitiligo. It would be larger than 1 centimeter, and if you close your eyes, you would not feel it. As opposed to a papule, which is the converse of a macule. So it is less than 1 centimeter, but it is raised, so you would feel it. So something like molluscum here, or an acne papule, where if you closed your eyes, you would feel it. It's raised off the skin, less than 1 centimeter. And then plaque is greater than 1 centimeter and raised off the skin, like a psoriasis plaque or an eczema plaque. So those are the 4 basic ways to describe a skin lesion or rash. So you have papule, plaque, macule, patch. So, and they're all related to each other. Less than 1 centimeter, greater than 1 centimeter, can feel it, can't feel it. So papule and plaque you feel, macule and patch you don't, and then you look to see how large they are. Vesicles are less than 1 centimeter, like a papule is, but they are fluid filled with clear fluid. So they're not filled with pus, and they're not just bumps. They actually have specific type of fluid, clear fluid in them. And an example would be something like HSV, where you see these, I'm going to use some adjectives now, cropped vesicles. So you know they're cropped, they're in a group together. They're vesicle, now you know they're fluid filled on an erythematous base. If I said cropped vesicles on an erythematous base, you would immediately know that's HSV without ever looking at this picture. So that's what I mean when I say if you describe something well, I'll know exactly what it is before I even see the picture. As opposed to bullae, which are greater than 1 centimeter, They can be flaccid or tense, and they're usually fluid filled. So an example would be something like bullous pemphigoid, where you get large, tense, or flaccid bullae. Contrast the vesicles with pustules, where instead of fluid filled with clear fluid, they have pus. And this is an example of pustular psoriasis. This is not an infection. Certainly pustules could be an infection, but in this case, I'm showing you an example of pustular psoriasis. So again, you see this erythematous base. This might be in a symmetric bilateral distribution. You'd say infections shouldn't be symmetric and bilateral usually. They're usually just in one spot. And this is an example of pustular psoriasis. So here are some of the morphologies. So we can describe things as scaly, as crusted, lichenified, or thickened. You can see eroded, where the superficial epidermis has been eroded away, excoriated or scratched. Fissure, where you have a cleavage line in the skin. You could see ulcerated, where the top epidermis is completely gone and now it has an ulcer there. You could see an eschar or petechiae. So petechiae, little purplish, little pinpoint purple areas. You could see ecchymoses or purpura, different ways to describe essentially bruising or blood out of the normal occurring extravascularly. You can also see patterns of rashes. So you're probably familiar with the dermatomal pattern, but there's more than just dermatomal. So dermatomal, as you know, along the line of runs along the way that a nerve runs, versus something like Blaschkoid, for example, where it runs along the line of embryonic stem cell development. So the pattern's a little bit different. We talked about clustered. Annular is a common one. Annular means annulus. Annular means round or circular. Annular is another one. You could also see linear, that are in more straight lines. You could see follicular, that occurs along the hair follicles. So different ways to describe a pattern of a rash. There's also something called the Koebner phenomenon, which you should be familiar with. So just like dermatographism, where you have an urticaria patient and wherever they scratch, they get lines of urticaria, you can also see that in inflammatory skin conditions. The two most common that do that are psoriasis and lichen planus. This is an example of psoriasis, which is Koebnerizing. So Dr. Koebner was the one that described this phenomenon. So we call it the Koebner phenomenon. And essentially, it looks like dermatographism, but it's of their inflammatory skin disease. And you could see this just with relatively little trauma to the skin. But if someone has surgery, for example, and they have an active psoriasis issue, they could develop psoriasis along the lines of their surgical incision, or just from scratching, like the person here, where you get psoriasis plaques. So this is the dermatomal distribution. You can see the way that different nerves run. Don't miss a dermatomal distribution on a patient, because that usually means there's a problem with the nerve. The two most common things that do that are either shingles, where someone is developing a rash, or sometimes just burning and stinging or itching predates any rash, and all they say is, I'm getting this burning, stinging, itching phenomenon, and it's in one side of their body, and it's unilateral in a dermatomal distribution. They're about to develop a shingles rash, and the sooner you could treat it with something like valacyclovir, the better off the person's going to do, the less likely they're going to have neurologic morbidity that lasts potentially the rest of their life. The other thing to remember is, if you see someone who has chronic itch, chronic pruritus, and it's unilateral in a dermatomal distribution, it's not bilateral and everywhere, and like they're just picking at their skin, but it's in one particular place. Think about nerve again. This is dermatomal. What's wrong with that nerve underneath? Maybe there's something impinging on the nerve. That could be the intervertebral discs that are impinging on the nerve as it exits the spinal canal. Or it could be a tumor that is also impinging on that nerve, and something that you want to diagnose and get the person to a neurologist and a neurosurgeon. And I've seen that where doctors miss this for years because they don't realize that the person's chronic itch is not urticaria, it's not prurigo nodularis, it's not psychogenic, it's in one area of their body and they're scratching at that same area, and it's actually a tumor that's compressing their nerves. This is what Blaschko's lines looks like. So it's more of a V shape over the back and an S shape or world shape over the chest. So you can confuse this with dermatomal, but it's actually a little bit different. And I show you an example of this called lichen striatus, which is a relatively common pediatric disorder that you could mistake this for allergic contact. You could mistake it for a dermatomal distribution. But if you're familiar with this condition, where you see these confluent pink papules that coalesce into a plaque, and it's in this linear Blaschkoid distribution, this is a classic example of lichen striatus. It does not need any real intervention. You just tell the parent this is what it is, and it's going to go away as the child grows up. It's usually not very itchy, or you can do some triamcinolone if it's really bothering the kid. But you're going to see this in your career. It's pretty common in the dermatology office, and you just need to make sure you tell the parent what it is and not misdiagnose it and do patch testing and all this other stuff. Okay, so we said one of our objectives was let's focus on some diseases that are associated with atopic dermatitis. So you're familiar with atopic dermatitis, erythematous eczematous plaques, classically on the popliteal fossa, the antecubital fossa, cheeks of a child, not eyebrows, eyelids, etc. So you're very, very familiar with atopic derm. We have some amazing treatments for it these days that have drastically changed the way we treat atopic derm. But let's look at some things that are sort of associated or could be related to atopic dermatitis. So one is allergic contact. The reason I say it's associated is these do not always occur in isolation. Your atopic derm patient is also your allergic contact patient. So if they're prone to atopy, they're also prone to allergic contact issues. So just remember the history is very important, but you want to tell the patient, I need to know what you did 48 to 72 hours before this rash started. They're going to want to tell you what they did, 10 minutes before it started. Oh, I ate this for lunch or whatever. You just say, no. These rashes require the cells to communicate. I need to know what happened 48 to 72 hours before, because that's how long it takes the cells to communicate. Now that you're aware of that fact, please keep a little diary or something and let me know what you've been doing, the couple days prior. So you basically need to do avoidance of the contact allergen if you can find it, topical steroids, etc. But what you don't want to do is have the patients do where they're shotgunning all these different things and foods and whatever. You need to deprogram them of that. And also, I tell the patients your skin's default is healthy. So if we just take away everything you're putting on your face or whatever, your skin's going to get better. But if it's a woman and they use 10 different cosmetics and they're using a lot of stuff on their face, you have to say, listen, you came to me with this, you're very you're upset about it, it's really bothering you. We need to remove everything, and then we replace things one at a time, a week apart. So if there's a trigger, we'll identify it, even if we can't identify it on patch testing. So there's a concept called spongiotic dermatitis that you need to be aware of, because my concept here is if you biopsy what you think is an eczematous dermatitis, the pathologist is just going to tell you it's an eczematous dermatitis. They're not going to tell you what subtype it is. So if you're trying to decide if it's atopic versus allergic contact versus irritant versus hand dermatitis, versus some other eczematous dermatitis, it's not going to separate those things for you. So normal skin is on the left here, and you can see this basket weave, nice orthokeratosis, which is what the superficial layers of your skin are supposed to look like. They don't have nuclei, as you can see, because they're dead keratinocytes there that are forming the barrier of skin. And then you could go down deeper and you see the normal layers of your skin. Versus in spongiotic dermatitis, you see spongiosis. You see this ballooning out of the cells here. So you see these white areas. You would see some nuclei in the superficial epidermis because the skin is turning over so fast that they don't have time to extrude their nuclei. So instead of this nice basket weave orthokeratosis, you're going to see parakeratosis, or nuclei in the superficial epidermal layers. But all of this boils down to spongiotic dermatitis, and you're going to get a readout from the pathologist that's /sponge derm, which just means they copied and pasted the description of spongiotic dermatitis, and it could be any of these things that are causing it. So pathology is great for differentiating between dermatitis and something else. Sometimes we need to do that. I don't know if it's psoriasis or dermatitis. They can look very similar. Let's biopsy it and see if it looks more like psoriasis or more like dermatitis. I want to know if it's CTCL. I want to know if it's scabies. I want to know something else. Yes, that's very helpful to help differentiate it. But if you're trying to differentiate between subtypes of dermatitis, that's done on a clinical level. It's not going to be done on a path level. Your path is just going to look like sponge derm. You're going to confirm that you have a dermatitis here, which might be helpful for you, but you're not going to rule out subtypes of dermatitis. That's not possible. So some diseases associated with eczema. So the first is flesh-colored umbilicated papules in an area of eczema involvement, like the antecubital fossa here. So this is molluscum contagiosum, and that's exactly what you see. There's always some debate, does the dermatitis start off the molluscum, or does the molluscum start off a dermatitis? I think mostly if you have a broken down skin barrier, your skin is more prone to getting viral issues. like eczema herpeticum and also molluscum contagiosum. But you need to treat the dermatitis and repair the skin barrier, and you also need to do something to attack the molluscum virus that is now infecting the skin there. It's classically seen in childhood on opposing skin surfaces. If you see it in an adult, it's usually in sexual areas because that's where the skin-to-skin contact has been. But most of the time you see it in childhood, and you see this eczematous inflammation. Here's an example of a very vigorous eczematous response associated with molluscum contagiosum here. And what you want to do is treat it with something to destroy the molluscum. So you can do destructive modalities like cryotherapy, where you use liquid nitrogen. You can use cantharidin, which is beetle juice, which will cause a blistering reaction on the skin. I personally like intralesional candida. So if you use the same candida extract you would use for intradermal skin testing, 1 to 100 or 1 to 1,000 dilution of the stock dilution of candida, and you inject that intradermally right into the molluscum lesion, has an amazing response, and it triggers the immune system to target that molluscum. It samples it and starts to attack all the molluscum. So if you have all these little molluscum bumps all over, you could just inject 2 or 3 of them, and they all start to do this and get red and irritated and start to go away because the immune system is attacking it. Or you can use a cream called a imiquimod cream, or the brand name is Aldera. It's a TLR7 agonist, so toll-like receptor 7 agonist. It's available commercially, very easy to get. Every pharmacy pretty much has it. And you apply a tiny little amount, like a toothpick or a Q-tip, head of a toothpick size, on each lesion, Monday, Wednesday, Friday for like 6 weeks, and they get the same response. They get red, irritated, the immune system starts to attack them, and they go away. So I don't really like destructive modalities, which are painful and cause scarring when you have something like this or something like this. I prefer candida. I think it works really well. You only have to inject a couple. It really doesn't hurt. It's an intradermal. It's just, you barely feel it. After 3 months or so doing that, usually your immune system has responded. Okay, cropped, punched out, yellowish crusted papules on an erythematous base on this young child who has eczema. I just described that to you. You shouldn't even need to see the picture. If I say cropped, punched out, basically anything that's cropped is going to be in the herpes virus category. And if you see these punched out lesions, it's just pathognomonic for herpes. So this is eczema herpeticum. Sometimes patients I've seen have to be hospitalized for this because it's so widespread that you really need IV acyclovir or valacyclovir. You can easily scrape the base of one of the lesions and send it off for viral PCR, viral culture, and you will get HSV, and you want to treat with acyclovir and valacyclovir. You want to start that as soon as possible and be pretty aggressive with it so they don't get any other sequelae, but this can be a pretty widespread complication of their atopic dermatitis. Another related disease to atopic patients, this is yellow, honey-crusted, papules and coalesced into plaques with an erythematous base. Again, the tip off here, hopefully you can all appreciate the honey-crusted nature of these lesions. And this is impetigo. So this is from people usually scratching with their fingernails and introducing staph or less likely strep into their broken down skin barrier. You could sometimes see bullous impetigo where you get flaccid bulli with clear yellow fluid in it as well. This is usually secondary to their atopic dermatitis and their skin barrier dysfunction. And it's more common with Staph aureus, but you could see group A strep as well. And be aware of post-streptococcal glomerulonephritis because we treat strep pharyngitis because that is a potential issue. Eventually strep pharyngitis goes away, but you don't want the post-strep glomerulonephritis or the rheumatic fever, obviously. But the post-strep glomerulonephritis is actually more common if it's a skin infection than it is if it is a strep, if it is a pharyngitis. So be aware of that. If you see if you culture strep, check some kidney function and then monitor that, over the next several months to make sure there's no issue there, and treat with an antibiotic like a first generation cephalosporin or similar. Okay, hypopigmented, not depigmented, hypopigmented patch, slightly scaly on the left cheek. Usually it's not really scaly, but it's actually just more xerotic or dry. And you can see this is in a patient who has underlying atopic dermatitis. So this is a very common one you're going to see a lot. Pityriasis alba. It's more common in darker skin patients. It really should not be scaly, but more just dry and associated with their atopic dermatitis. If you see outer ring of scale, that is more consistent with a fungal infection. If it's totally depigmented, where there is no pigment there, that's more consistent with vitiligo. But in a young patient with a history of atopic dermatitis, it's pretty much always going to be pityriasis alba the vast majority of the time. And you could KOH it and scrape it if you're not sure. Or you could, if you don't know how to do a KOH in your office, you don't have a microscope, that's fine. You could take a little 15 blade and just scrape the edge, put it in DTM culture, which you could just have laying around your office. Just put the whole blade in your culture and send it off to the lab, and they'll see if they can grow fungus there. But if you see this on the cheeks or the upper arms of a patient who has eczema, most of the time it's just going to be pityrized as alba. Alba means white, and you'll make the diagnosis. And there's nothing really to do other than just emollients and treat their eczema. Contrast that with these oval, clustered, scaly plaques. They're not on the cheeks or upper arms necessarily. They're in areas where there's a lot of sebaceous glands. This is where a lot of oil likes to be produced on the skin. So you can see it follows along the hairline in a seborrheic or sebaceous distribution. And if you look at this, they almost look like little colonies of growth. Like they look like what you would see on a petri dish if you were going to grow colonies of something. And this is tinea versicolor. If you scrape it on a KOH, like the one I did here, you could see branching hyphae and some of these little, we call them like macaroni and meatballs or penne and meatballs, where you see hyphae along with the little eggs associated with this fungal element, and you treat with topical antifungals. So I'm just contrasting this with this. So these are just flat, relatively non-scaly patches, not in a seborrheic distribution. This is in a seborrheic distribution, following along sebaceous lines, like along the hairline and the back of the neck, and it looks like these little petri dish looking like clusters of organisms. Okay, now let's look at some diseases that are associated with itching and scratching. So the first one here is a hyperpigmented circular patch that's intensely itchy or burning, and it's over the scapula. So look at what we have here. Hopefully your red light's going off in the back of your mind, because you see a unilateral dermatomal distribution here. And if you see brownish, that's usually because you're laying down amyloid, which is from intense scratching and nerve issue, basically. So think about if the wiring behind your wall, if you ever had like a wire blow or something behind your wall and it like pops and then you get this brown discoloration on your wall. That's what's happening with the electrical wiring in your nerves right now. So you get this amyloid laid down, and it is this brown, intensely itchy patch over the scapula. I see this all the time, and this is called notalgia paresthetica. It's pruritus that's due to nerve entrapment, usually somewhere between T2 and T6, but you can see this in other areas. There's something called meralgia paresthetica, for example, where people who are wearing like tight pants or horseback riders and things like that, where it's along the iliac crest of your pelvis, and you get that same sensation, but it's over your lateral thigh, and you get the same kind of look. But notalgia paresthetica is the most common one, and we actually treat it with topical capsaicin usually, which is the ingredient in hot peppers. So that's what makes hot peppers really hot. And they have capsaicin cream where you can do a desensitization protocol to make the nerves like fire so much that they blow other neurotransmitters and allows the system to reset. You can also use topical steroids, sometimes Neurontin. And again, you'd want to make sure that it is just nerve entrapment and there's not something impinging on the nerve like a tumor in that area. So you'd want to be alert to that and potentially refer to a neurologist to have them examine the patient. Another scratching condition is lichen simplex chronicus, or LSC. This is really a secondary condition. So lichen simply means a lichenoid distribution on pathology. When something is lichenified, we usually are talking about that it's thickened with extra lines. So you can see how this is all thick with like extra skin lines there. This is lichen simplex chronicus. And the take-home point here is it usually starts off life as something else that makes the person start scratching at this area. And then they just keep digging, and it creates this extra skin barrier here, which we call lichen simplex chronicus. The primary thing that caused this might be long gone, and now they're just scratching at this area and just having a vicious cycle. And I think the take-home point here is you want to use keratolytics, because if you just apply topical steroids to this, you're putting it on a shield of lichenified hyperkeratotic dead keratinocytes. Remember I showed you in the pathology, these are dead keratinocytes with no nuclei. Well, how does steroids act? They act on the nuclei, right? They decrease transcription in the nucleus. If there are no nuclei, your steroid's going to be ineffective. So you're trying to get your steroid down to the deeper layers of the epidermis that do have nuclei, but you can't because this is so thickened. So you need a keratolytic agent like urea 40% lotion, amlactin like ammonium lactate, or lachydrin 12%, where you can do something to degrade these dead keratinocyte layers and get then you put your steroid on and get it down to the layers of the nuclei. So if you put even clobetasol ointment on this, you're not going to do a darn thing until you get the extra layers of dead keratinocytes out of there. And that's what that basket weave orthokeratosis or parakeratosis I was showing you in the pathology is those would be extra layers of dead keratinocytes. Contrast this with prurigo nodularis. So this is where someone is picking at their skin chronically. I want to make a couple of points here because this is a very difficult condition for a dermatologist or an allergist to treat. The first is this is a primary diagnosis. Okay, there is an ICD-10 code for it. We have treatments for it. So right now, dupilumab is FDA approved for the treatment of prurigo nodularis. We're going to have nemolizumab, which is an IL-31. That is also, I think, going to get approval fairly soon for prurigo nodularis. So we're going to have actual biologic agents that we can use to treat prurigo nodularis that are and will be FDA approved for it. So this is a primary diagnosis. However, it can occur wrapped around another primary diagnosis, like someone who has PTSD because they're a veteran of war, or someone who's having mental health issues, or someone that has a kidney issue or a liver issue or any other reason that someone would be itchy and they're chronically picking at their skin. So you have to treat the primary problem, and you also have to treat the other primary problem, which is now, regardless of why it happened, they have prurigo nodularis. And I don't want you to think of these lesions as a result. They are a result of picking, but they're also the cause of the person's picking, because these are filled with hyperinflammatory immune cells producing lots of IL-31 and other itch-related cytokines, IL-4, IL-13, IL-31. That whole pathway is being activated here, because when you're picking at your skin, your immune system's not just ignoring the fact that you're picking at your skin, you're having an immune response to it. And these actual lesions that are now fibrotic and have things like periostin and other things in them, those are not just scaffolding, they're not just fibrosis, they're not just scar tissue, they actually are also billboard signs for your immune system to say, hey, we have a construction site here, here's the construction billboard, everybody come here and start making more inflammation. So you have to do something to calm down the inflammatory component, you have to do something to address whatever the other primary concern was, if it still exists. But don't just look at these and say the person's doing this themselves. Those lesions in and of themselves are now itchy and triggering an immune response. So you have to look at it both ways. And you could do things like inject triamcinolone into these, very effective. Like I said, some of the biologic agents that currently exist and are coming. I like Cordran tape. So it's tape that is impregnated with steroid. Very effective when you put it on these because it helps the steroid penetrate. And it also reminds the person not to scratch. If you don't have the tape or it's too expensive, you could just put steroid on it, like clobetasol or something, and then put like a Band-Aid over each one. This is the extreme example, neurotic excoriations. This patient was a veteran that came back from war and was chronically digging and picking at their skin due to mental health issues. And you can see that yellow stuff you're looking at, the shiny yellow stuff, that's subcutaneous fat. So he went completely through his dermis into the subcutaneous fat. Okay, another itch condition, erythematous eczematous plaques. Some of them with pinpoint papules that's distributed along the dorsal hands, the inner thighs, and the genital pubic areas. So when you see dorsal hands and lower abdomen, genitals, pubic, you're thinking of this diagnosis. And this is one of the reasons I ask when someone comes in with a rash, do other people at home have the rash? If you're thinking this is allergic contact or eczema or something else or hand dermatitis, that is not contagious. So that's an easy question to ask a patient. Do other people have this? Because if the answer is yes, you should start thinking about some sort of infestations or something that is transmissible to somebody else. So, and the other point to make here is if you never looked at their genitals, you never saw the genital rash, you only saw the hand rash. If you just saw that hand rash, you could easily think that that's a hand dermatitis, allergic contact, irritant, oh, you're a nurse, do you just wash your hands all day? No, none of that is true. In this case, this is scabies. And if you scrape a lesion and put it under the microscope with some mineral oil and you get lucky and you get a good scraping, you could see an actual scabies mite. This is one that I did myself in the Children's Hospital when I was a dermatology resident. And you could see these little scabies mites that'll be alive and swimming around in their skin. So the tip-off here is webbing of the hands, contagious, pelvic area, abdominal area, and they cause a delayed type 4 hypersensitivity reaction, which means that a lot of what you see with the rash just looks like id reaction, allergic contact dermatitis type looking stuff. So if you don't see some of these little tip-offs, you could easily just mistake this for some sort of eczematous dermatitis. You treat with permethrin cream. I really like ivermectin because it's a single dose, then you just repeat it after 2 weeks. So for most adults, for 200 microgram per kilo, it's like 15 milligram, which is 5 tablets or so, because each tablet is 3 milligram, and you just repeat that in 2 weeks. And if you're not sure, you're like, I'm not great at diagnosing this, but I'm wondering about it. It's questionable. They have some hand involvement. Maybe there's some general involvement. I'm not sure. I don't know how to do a scraping. It's 3 months until I could see a dermatologist or whatever. Just treat them. Just give them the dose of ivermectin. You're not going to harm someone with that. And I just tell people it's like a nuclear bomb for stuff for infestations that's in your skin, like scabies. And if I'm wrong, no harm, no foul. If I'm right, I'm going to make your rash totally better and you're going to be happy. If you miss scabies for an extended period of time and you do things like prednisone tapers or intramuscular Kenalog or tons of steroids or whatever, and then it turns out a year later they had scabies for the past year, those people get pretty upset with their providers because they're like, I had bugs in my skin for a year and you were giving me systemic steroids and stuff. And I've seen lawsuits happen because of that. I've seen 3 lawsuits where they sued their provider for missing scabies for an extended period of time. I was like, dude, you could have just given them 1 dose of ivermectin. You would have been totally covered and you wouldn't have harmed the person if you were wrong. So I'm not saying to give everybody with dermatitis ivermectin, but if you're not sure and it has some red flaggy stuff, make sure you check the genital area, get the person in a gown, and have a low trigger for ivermectin. Okay, now we're going to go on to diseases you could mistake for eczema. So the previous things were things that could be associated with eczema or looked a lot like eczema. Now we're going to look at things that you could mistake for eczema. So let's start with some facial rashes. This is one everybody since the pandemic should get right, but I still see people miss this quite a bit. So this is erythematous. These are acneiform pink papules on an erythematous eczematous base that is hugging right up against the nasal ala. And are also perioral on the chin and nasal areas. So I basically gave you the diagnosis here. This is perioral dermatitis or periorofacial dermatitis. It just loves right up against the nasal ala like this. If you see that, and it's a little kind of this combo acne eczema look, perioral dermatitis, you have the diagnosis. Steroids make it worse. It can be around the eyes as well. So here's an example of periorofacial dermatitis around the eye. Again, you see this acne look. You also see this eczematous base. And I love treating with oral doxycycline. You need to treat for 1 to 2 months, which is the same treatment course that we use for an acne patient. It's very effective. It's almost 100% effective in my opinion. You can also use clindamycin topical or Elidel topical. I find those are much less effective, probably 50% when you use those in combination. And it takes a while for it to go away either way. So I really like oral doxycycline. Remember, steroids trigger this. So if someone's wearing like a mask with their asthma steroid inhaler, they can get the steroid all over their face and they can get periorofacial dermatitis from that as well. So just be aware of this condition. It's one you're going to see a lot. Okay, another facial rash that you can mistake. So this is erythematous eczematous plaques. But if you look, it's liking the nasolabial area. It's also liking around the hairline and the eyebrows. But the tip-off is this stuff right here. So you could see this yellowish, greasy, scaly plaque. So I'm kind of trying to convey to you this is a seborrheic distribution. So eyebrows, hairline, nasolabial folds, that's where a lot of oil likes to be produced. You could mistake this for perioral dermatitis, but this is pretty widespread for perioral dermatitis, and you don't get these greasy areas and flakes, especially in the nasolabial folds or the eyebrows. So this is seborrheic dermatitis. Yes, you could see this on the scalp of an infant, then it's called cradle cap, or still seborrheic dermatitis. It's an inflammatory reaction that occurs from the naturally occurring Malassezia yeast that's on everybody's skin. Some people's skin decides it doesn't like it there and it starts to make an inflammatory reaction. We usually treat it with something that treats the fungal component and also treats the inflammatory component. So something like ketoconazole cream or a topical steroid like Desonide ointment or cream, for example. Now there is topical roflumilast, which is it's not a cream, it's actually a foam that's FDA approved for monotherapy for seborrheic dermatitis. The cream is also approved for psoriasis. So that's a topical PDE4 inhibitor, phosphodiesterase 4 inhibitor. And you might be a little more familiar with this now than you used to be, because now this is also FDA approved for atopic dermatitis as a non-steroidal in the 0.15% cream. So 0.3% is approved for psoriasis, 0.3% foam is for seborrheic dermatitis, and 0.15% cream is now approved for atopic dermatitis. So nice that we have some additional non-steroidal options for these conditions, including now atopic dermatitis as well. Okay, erythematous papules that are coalesced into a plaque on the cheeks of this child. Usually the history for this will be the first real sun exposure of the year in the springtime when the sun comes out, or when we go on our first trip to Mexico for spring break or something like that. I get the same rash and it looks like this and it's always on my cheeks and I get it every year. That's called polymorphous light eruption. Polymorphous meaning it looks different for different patients, but it's monomorphic for an individual patient, meaning they're going to tell you I get the same thing every time. And the treatment is sun protection and sun avoidance. And also I usually pre-treat with some topical steroid like a mild Desinide or hydrocortisone 2.5%. And I start pre-treating a few days before their trip, before their sun exposure, good sun protection, and they usually don't get it. But this is called polymorphous light eruption. You could see it on the cheeks, you could see it on the arms, places where it's photo distributed. Okay, contrast these other facial rashes with now this one. So this is, you could think, like you could say, Mark, I thought this was seborrheic dermatitis, but look at the malar distribution of this. This is in a butterfly distribution where it looks like a butterfly. It's sparing, relatively speaking, the nasolabial folds because it's really liking where the face pops out and you're getting a lot more sun exposure. But the other thing that tips you off here, if you're astute to this rash of lupus, is this is thick. Like look at this one here, look at this. If you feel it, it feels dermal. It feels tacked down to the deeper layers of the skin because autoimmune skin rashes like lupus, they are dermal. Like they involve the dermal blood vessels. They go deeper down and it feels juicy. It doesn't feel like it's superficial on the top of the skin. It feels like it goes down deeper and it feels like it has some texture to it. So you're seeing a malar rash, you're feeling it and it's juicy. This is the dermal malar distribution of lupus. Okay, let's look at nummular dermatitis where we see erythematous, eczematous, nummular plaques. Nummulus means circular, or a nummulus in Latin is like coin. So this looks like coin shaped. So you could see that the tip off here, if this is nummular dermatitis and not something else, is see how these are filled in. Like it's not a ring with like some blank space in between. These are just filled in eczematous plaques. And it doesn't have like a ring of scale. It's just straight up eczema that's filled in as a circle. This is nummular dermatitis or discoid eczema. Basically, they're coin-shaped versions of eczema. It's easily confused with ringworm, but hopefully I gave you the little pearl there to avoid that. If you're not sure, you scrape the outside of it. Why do we scrape the ring? Because that's where the fungus is expanding out and living. The center area is where it once was, and now it's not there anymore. That's why the center area for ringworm is usually blank, and then you see this ring of scale around the outside. If it's nummular dermatitis, you treat it with a potent topical steroid. Here's another circular rash. So this is hyperpigmented, eczematous, usually a little bit painful or burny or itchy plaque on the head of the penis. I gave you the head of the penis because this is the standard pathognomonic distribution of this particular rash. And the person's going to say, I've gotten a rash here more than once. So this is fixed drug eruption. When you see that dusky brown or purplish look, that's pretty pathognomonic for a fixed drug. And usually they'll say they've had it there before. It's usually 30 minutes to 8 hours after the drug administration, so it's pretty quick. And once the drug is discontinued, it goes away within 7 to 10 days. You can leave some post-inflammatory hyperpigmentation there, but it should be flat, no longer scaly, and not painful or itchy or anything like that. These are the top two. So we talk about antibacterials like sulfa-based antibiotics, sometimes tetracyclines. And I see this quite a bit with NSAIDs like ibuprofen or Tylenol. So just be aware of fixed drug eruption, dusky brown or purplish, circular, usually in one spot. Usually it's the same spot. You avoid it. If you want to be sadistic, you can re-challenge them to that, and they'll get another rash there, and then you'll say, oh, I knew it was a fixed drug. If you want to be really sadistic, you could take a biopsy of the person's penile head. I recommend just diagnosing this clinically based on the history. And this is what I mean when I say post-inflammatory hyperpigmentation. I tell patients that's the paw print of where the rash used to be. In the case of nummular dermatitis or something like fixed drug, it's going to be in that shape, so mostly circular. And you just tell the person, these are because the melanocytes got revved up from all the inflammation here. This is the paw print of where the rash used to be. It's going to go away, but it's going to take time. It could take up to a year to go away. We could treat it with some hydroquinone, which is a topical cream that you can use to help fade and reduce the activity of melanocytes producing pigment if you were so inclined, if it was cosmetically bothersome to the patient. Contrast this with now, you clearly see this is still a nummular plaque with peripheral scale, but the center area is cleared. And this is now an example of ringworm, Tinea corporis. And you can see that it is, again, along areas where there's more oil and sebaceous involvement. Doesn't have to be, but in general, what you really want to look for is this central clearing on the classic ring where it's spreading outward, and you would want to scrape over here where the scale is the leading edge. So those are dermatophytes. There's various different types that cause tinea. If it's body, it's tinea corporis, foot is pedis, hand is manum, capitis is scalp. And again, you could scrape them, look at them at KOH and see some of the fungal elements, or you could simply just scrape it and send it for culture if you're not someone who's adept at using the microscope. Now, if you are treating a fungal infection with strong topical steroids, this is what you could do to somebody. It's called a Meioki's granuloma. You can see how this looks shiny and purple. It's still kind of a ringworm shape, but now it's just kind of gone wild and it's gone more dermal. And that's what happens is that the fungus gets driven deeper down into the dermal layers. And now instead of topical antifungals for a month or something, you've bought the person a 4 to 6 week course of oral antifungals. So that's why if you're not sure, I recommend just doing a culture and using topical antifungal creams to start. No harm, no foul. If you're wrong, it might be an emollient and help the person moisturize a little bit, but you're not going to hurt somebody. Contrast all of these. Now, you might think this is ringworm. I wouldn't fault you if you thought this was ringworm, but a dermatologist is not going to think this is ringworm, okay? Let me give you the features here. This is annular, so it's a circle. There is clearance in the middle. There is not any scale. It's not itchy. And look at those bumps. Remember the bumps I showed you with lupus? This also is dermal. This has juicy, it feels like there's dermal components. It has a thicker base to it. It's not just superficially sitting on top of the skin. It also happens to be on the dorsal hand, which is the typical distribution for this disease. Some people have one of these, some people have more than one. So we said it's annular, we said it's dermal or has these granulomatous areas on the periphery. So I just gave you the diagnosis. This is granuloma annulare. So it looks a lot like ringworm, but it has these features. It's dermal, no itch, no scale, still has the central clearing, but it has that circular dermal juicy component to the outside, and it's actually of unknown origin. It's a benign granulomatous inflammatory condition that some people get. We can inject this with something like triamcinolone. You can use topical steroids. Sometimes we'll use TNF inhibitors, which we use like off-label for that, which is a biologic like adalimumab or something like that, or etanercept. But most patients need no treatment at all. As long as it's not cosmetically bothersome to them, they can just leave it alone. Okay, another nummular thing, and this is one that transitions into not to be missed. This is an erythematous plaque with yellowish crusting. It's growing. It's on a sun-exposed area. It might be bleeding, and they don't know where they got it from. There was no trauma. There's no nothing, but now it's a bleeding erythematous plaque that is not going away in a sun-exposed area. I've seen people miss skin cancers and call them infections and nummular and other things. If they don't know where it came from, it's on an older patient, it's on a sun-exposed area, all of that kind of stuff. Be a little bit familiar with what skin cancers look like, because this just needs a biopsy and a referral to a dermatologist. This does not need steroids. This does not need antifungals, etc. So be aware with some of these features. I said we don't talk about growths, but I can see how someone could easily mistake this. But if it's shiny, bleeding, painful, growing, non-healing wounds, things like that, don't just, even if you culture an infection, that could just be secondary, and there's staph there, but it's staph sitting on top of their skin cancer. Okay, contrast this with now erythematous salmon-colored plaques with overlying white or silvery scale, and the nails are a nice tip-off to some inflammatory skin conditions. This is classic psoriasis here, so don't miss psoriasis. So the eczema is the folds of the elbows, the folds of the knees, the antecubital popliteal fossa. These are the extensor surfaces, back of the elbows, front of the knees, sacrum, belly button, scalp, nail changes, joint problems, and salmon-colored plaques with white silvery scales. And then we treat this with lots of great biologics we have these days. So don't miss psoriasis here. They're usually very well-defined plaques too. You also have guttate, where it's teardrop shaped. Inverse distribution of rashes, like plaque psoriasis, can be in the inverse distribution. So inverse means usually your private areas, so your underarms, your groin, your inframammary creases. You could easily mistake this for something like a candida issue or yeast issue, etc., under the mammary there. So intertrigo or something. But this is the inverse distribution of psoriasis, and you can get inverse distributions of lots of other rashes. I've seen atopic inverse distribution. I've seen lichen planus. Lots of inflammatory rashes can home to the inverse areas of your body. Okay, some diseases not to be missed. This is targetoid papules on the palms of an adolescent. I think this person was like 20 years old or so. So you see these targetoid papules. There's not too much that occurs on the palms. Syphilis can occur on the palms, or this diagnosis, which is erythema multiforme. The reason I bring this up is most patients, it's because of HSV1. So if you see a patient that has erythema multiforme and you see these papules on the palms, just say, I'm going to treat with acyclovir or valacyclovir, even if I'm wrong, it's from another virus or something like that. There's no other treatment for any of the other viruses that cause that, and most patients it's going to be HSV1. So you do treat with acyclovir or valacyclovir. You do not treat with prednisone, because prednisone will not make it better and could potentially cause a rebound. You actually could be elaborating a future HSV outbreak, and you'll put the person in a vicious cycle. So erythema multiforme, targetoid lesions on the palms. If they get mucosal involvement, then it's major, and you still are going to treat with acyclovir or valacyclovir, and you're going to see some terrible looking mouths associated with erythema multiforme major. Okay, the next thing not to be missed are these dusky purplish patches or plaques, that some of which are associated with bullae here. You could see some confluent erythema on the palms, and then you clearly see this mucosal stuff and mucosal involvement. This is something, if you miss it, the person could die. Okay, this is the derm emergency. Stevens-Johnson, TEN, you're very familiar with this condition, so I won't go over it in great detail. Definitely something not to be missed. So we talked about some of the cutaneous manifestations. This is Nikolsky sign, where if you put lateral pressure on a blister, the epidermis will start to detach. And you'll see some of the worst mucosal involvement you've ever seen in your life with these. Ideally, you pick this up in the earlier stages than that. You can calculate a score 10, which predicts mortality. And these are the causes. Just burn this stuff into your brain. Lamotrigine is one of the most common ones I see. Sulfa-based antibiotics. I hate Bactrim. I rarely, if ever, use it, only if I absolutely have to. But don't forget, NSAIDs have warnings for Stevens-Johnson. Acetaminophen also has warnings for Stevens-Johnson TEN. Just be aware of that, because some people, it's like they have a virus at home, but they've been taking ibuprofen or Tylenol, and then they come in for Stevens-Johnson, and people just assume it's mycoplasma or something, and they keep giving them Tylenol or ibuprofen for their fever, because why not? And then they come mycoplasma negative, and oops, they were on Tylenol, ibuprofen. I just gave it to them Q6 hours for the past 2 days. Now the person's in the burn unit, trying to die. So just be aware. Stop anything that is not absolutely essential to their care, or anything that they were using at home, because you don't want to be wrong and be giving them a drug that is actually causing their problem. I recommend lymphocyte transformation testing, especially if you're not sure what agent is causing their disease. If it's positive, it can be helpful. If it's negative, doesn't necessarily help or hurt you. But I do like lymphocyte transformation testing if you can do it, especially if the diagnosis of what drug is causing it is in doubt. If you're not sure what this is, your immunology lab at Children's Mercy, or wherever you are located listening to this, most likely they can do that test where they expose lymphocytes to the drug, to the whole drug, and they see if you get a monoclonal T cell response. I very much advocate for this. If I ever show up at one of your ERs and I have Stevens-Johnson or TEN, I want to get a etanercept first and ask questions later. You're never going to harm someone by giving them this. You're blocking TNF-alpha, which is one of the main drivers of these monoclonal T cell responses. And there's a lot of articles way beyond this article now that show that this reduces mortality and the chances the person's going to walk out of the hospital and be okay. So prednisone, I don't like it. Solumedrol, I don't like it unless like ophtho or pulmonary wants it. IVIG, I think it's mixed. Sure, do it. Give me this in the ER, like immediately. Give me an injection of etanercept. Okay, another one not to be missed: erythematous, well-defined plaques, usually in the bathing suit distribution, so not where it's sunny, where it's not sunny, and sometimes it can progress to more plaques and tumors here. I've seen this misdiagnosed as psoriasis and eczema and all this other stuff. This is CTCL. Tip-off is the bathing suit distribution. Itchy, not getting better with typical therapies. Sometimes you can see this like tissue paper look to it, where the skin is more thinned out there. That's another tip-off. Usually it's in middle-aged or older patients typically. Sometimes you can have total body erythroderma with it, where the whole body is red and scaly. And you need to diagnose this with a biopsy with a pathologist that really knows what they're looking at. There's a significant delay from presentation to the actual diagnosis. That gets dramatically reduced if you send it to a pathologist with good expertise of CTCL. And what you see is too many cells for too few inflammation. There's not a lot of spongiosis here. There's not a lot of inflammation. But you see these lymphocytes that are homing to, they have so-called epidermatrophism, where all these little purple lymphocyte cells are homing to the skin, and they're making these little potries, microabscesses here, but it's not like there's a big infection going on. It's not like there's other inflammation going on. And those are all monoclonal cells. It's a cancer. It's a lymphoma. So all these are monoclonal lymphoma cells that are homing to the skin and causing the rash. And that needs a biopsy and then referral to oncology. We talked about shingles and the dermatomal distribution. And then don't miss bullous pemphigoid, another one not to be missed. This can have an urticarial phase, so you could see it and just think it's chronic urticaria. If you diagnose urticaria in someone who's 60 or older, ask yourself, why is this not the urticarial phase of bullous pemphigoid? Consider a biopsy with immunofluorescence, and you will see IgG antibodies lining up very nicely along where these proteins are mutated and it's causing the bullae and the split. But you can diagnose this in the urticarial phase. Just remember, BP is an old person diagnosis, I would say 60 and up, and bullous pemphigoid, not chronic urticaria. And then lastly, pink scaly papules on the forehead of someone who's got a lot of sun exposure. I bring this up because don't mistake zebras for horses. If you have a ton of sun exposure and you're getting a lot of these papules on the face, this is nothing more than actinic keratoses, which are pre-malignant cells that need to be treated with a cream, like a chemotherapy cream or cryotherapy or something to destroy those cells. Lastly, a word on topical steroids. You're afraid of them because they cause atrophy, telangiectasias, and stria. My rule, the Serota rule, you can't go from disease to damage. You have to pass through normal. You have to pass go. So you can put a strong steroid on this. Don't put a strong steroid on that when it looks normal again, and you won't get that stria and telangiectasias, etc. So don't be so afraid of steroids. You can use strong steroids on the face as long as you're using them where the disease is, and then tell the person to stop once they're better. That's what I use, so you can just look at this later or screenshot it. But desonide is low strength, clobetasol is super potent, and the in-betweens there. And I use a lot of the non-steroidals these days, like the topical ruxolitinib cream for eczema or the topical roflumilast now for eczema. So we're kind of getting away from steroids, but here's what I use for steroids. And again, I advocate